So yes, I've been asked to discuss our experience with IMiDs, and I'll start, of course, with thalidomide, which is the first IMiD we have used. But I know you guys have lots of experience with thalidomide. You probably have more experience than I have, because we have access to Revlimid since 2005 in France. So since 2005, we don't use much thalidomide. And you probably have much more experience than we have.
Am I right? Marcus.
So you know about single agent thalidomide in relapse refractory setting. I know about one of those studies, Yakubaga et al., that is a French study conducted by IFM. And as you know, we have been trying to use several doses from 50 to 800. 800 looks very toxic, you know that. I don't know which dose you use now, probably 200, even 100, decreasing to 50. And you know that in many patients it shows some efficacy. However, thalidomide monotherapy is not very active. Well, it is active, but not as active as if you combine with dexamethasone. So thalidomide dexamethasone is an extremely good treatment for early refractory. In my experience, it does not work very, very nicely in late relapses, in patients with many lines of treatment. But like in first relapse or second relapse, it could be very effective, especially in combination with dexamethasone. So I won't go too much in details. I just share with you that, in my opinion, you must know that the 3-year probability of survival, it's not PFS, it's survival actually, is just 60%. So a 60% 3-year survival is not really amazing. But at least it gives you some idea about where we start and from where we start and from where we want to go. Is lenalidomide going to be able to do better? And at some point, will pomalidomide, again in the end of my talk, being able to beat a 3-year overall survival 60%? Now, I just wanted to share maybe the sole experience I have with thalidomide, which is a study presented at AHIHA this year by Laurent Garderet, recently published in Blood. It is called MMVAR trial. It's a combined IFM-EBMT trial. I don't know if you participated to this study. It was a comparison of Velcade, bortezomib, thalidomide, dexamethasone, compared to thalidomide dexamethasone in patients, most of them first relapse following autologous transplantation. So the design of the study was this one. Arm A received VTD, Arm B received TD. Initially, the patients were not started with thromboprophylaxis, but very quickly on, when we experienced the first thrombotic event, we made a recommendation for all the patients to have a thromboprophylaxis treatment. Most of them were on low-weight molecular heparin. I show you 2 slides about that. So pretty much the data, primary endpoint, it's a phase 3 study, so primary endpoint was time to progression, pretty much, and those are the data. But again, it's published in Blood now by Laurent Garderet, so you might be able to get those data directly online. You could see that VTD, the combination of 2 novel agents, including thalidomide, actually does much better than just thalidomide and dexamethasone. So it's very interesting. It says that it's not just because you have a great drug, thalidomide is a great drug, that you're going to be able to do something amazing. You also need sometimes to have a great combination, which is easy to do in early relapse, which is much more complicated to do in very late relapse, because in very late relapse, patients are refractory to many agents, so it's hard to combine. But in very early relapse, it's easy to combine, because the patients are still sensitive to many kind of agents. The time to progression was also very good in patients that had 1 autologous transplant as compared to those that had multiple autologous transplant. And although I'm not showing that here, it was also very good in patients that had priorly 1 line of treatment as compared to those that had 1 or 2 lines of treatment priorly. But then clearly VTD is a way to improve on thalidomide dexamethasone treatment at first relapse and second relapse. Overall survival was not different, not statistically different, but again, the follow-up is quite short. but you could see that at some point we believe that with more follow-up we might see a difference, and if we can show an overall survival difference, that will prove that VTD really makes a huge difference, because when you show a difference in terms of PFS or TTP, it proves that the drug is very effective. But when you can show a difference in terms of overall survival, while eventually Velcade can be given in the TD arm later on in the disease, that proves that this combination is extremely active, at least to my point of view. However, there's a price for everything, and the price for the much higher activity of this combination came with peripheral neuropathy. And actually, in the IFM, we were in trouble with this study because we started the study in 2005. Actually, this study is a 2005-04 IFM study, so we started in 2005, and we included most of the patients during 2 years, and then after we stopped in the IFM, the inclusion, and only the EBMT centers ended the inclusion rate because of this. We thought it was unacceptable to patients in France to suffer from grade 3, 4, 31%, one-third of them had an extremely damaging neuropathy. And we thought that this was, in 2005, it was okay, but we believe that in 2007, 2008, it was unacceptable. So we stopped to include patients, and EBMT maintained the inclusion rate and was able to close the inclusion rate. However, we stopped because it was really unacceptable for us, especially that you must know that although neuropathy from Velcade recover neuropathy from thalidomide, most of the time patient keeps some sequelae. So it's really an issue. Now, the rest of the side effects, grade 3, 4, are very easy to deal with. The main issue for me was really peripheral neuropathy. Again, as you can see here, peripheral neuropathy started at a very high rate very early on, which is really an issue because if you want to get the best of this combination, you must go through at least 8 cycles, 6-8 cycles. But if you already have 15% of your patient having a neuropathy at 6 months, it's unlikely that you'll be able to go through really the entire protocol, meaning at least 8 cycles. So it's really an issue. Now, clearly VTD is effective, but I really hope that at some point we will be able to get rid of thalidomide in myeloma treatment, although it remains in myeloma treatment because it is so effective and great. It combined very greatly, very nicely with Velcade, actually. I think the best combination, we should ask Shaji his opinion on that, but I think the best combination of bortezomib is thalidomide, and the best combination to thalidomide might be bortezomib. There's nothing to prove that. There is no study that has proved that. But in my experience, and I have used PAD, bortezomib, adriamycin, dexamethasone. I have used Velcade, cyclophosphamide, dexamethasone, Velcade, thalidomide, dexamethasone, etc. Any kind of combination with bortezomib and thalidomide, and I do believe that VTD is probably the most effective regimen with thalidomide and with bortezomib. Now, another VTD that you must know, but this one is not called VTD, but VDT, which is, in fact, you keep bortezomib, you keep thalidomide, but you replace dexamethasone by doxil. This combination actually is extremely active, extremely toxic as well, actually, but extremely active. I just wanted to share with you this sort of very dramatic treatment. And to answer your question, what you could give to your patient that we might have slightly discussed during the afternoon, this is an extremely active treatment, but quite toxic, especially in terms of thrombopenia and neutropenia. Now, what we know in Europe and what we know in France better is lenalidomide, of course, because we were lucky. We participated to the study, the registration phase 3 study. We were part of it, so we could have access to lenalidomide on a very large scale since 2005, and it has been very quickly approved after that in Europe. And first relapse, as you may know, at least in France. You know this paper from Thanos Dimopoulos, so I should not have mentioned leukemia because both the paper of the MMO9 and MMO10 were published in New England Journal of Medicine by Donna Weber for the US study and by Thanos Dimopoulos for the non-US, the rest of the world, if I should say, international study. one thing you must keep in mind is, and we're not gonna talk too much about dexamethasone because dexamethasone is an old control arm, and I guess we do not believe you should give dexamethasone monotherapy to patients with myeloma, or maybe for a very short period of time. But for a long period of time, of course, you want to be very effective. And actually, you can see here that lenalidomide dexamethasone in patients that have been priorly heavily pretreated, you could get 60% response rate. And keep in mind that there is no minor response here. Those are as per IMWG criteria, meaning partial response and better. Now, and you can see that if 60% of the patient get a partial response and better, half of them got at least a VGPR and complete response, 15% complete response. Quite amazing if you think that those patients had 3 to 5 prior line of therapy. So it's pretty good result. And of course, it impacted survival, PFS and overall survival. And again, you have to keep in mind that in late relapse, let's say late relapse, 1 year PFS, 1 year TTP, but it's not exactly PFS, but it's a little bit close. 1 year TTP is what you could get as best so far in patients that have been a lot pretreated. And of course, dexamethasone only gives 4 to 5 months TTP, which is what you would have expected. Now, what have we learned more about Revlimid? Here you could see the benefit in terms of overall survival. That is much better, 38 months. So it goes much better than far beyond the treatment with lenalidomide. Because if the median time to PFS, the median time to progression was 1 year about, and the patient lived much longer than 1 year, that means that not only they were salvaged during the treatment with Revdex, but they were also able to jump, to switch, to go for other treatment after lenalidomide and dexamethasone, which bring their overall survival, median overall survival to 38 months. So that's pretty good a result. What we have learned from sub-analysis of MMO9 and MMO10 studies, because there were lots of patients included in those 2 phase 3 studies, was that the earlier you use Revlimid, the better you would get benefit from that drug. So if you wait the 4th, 5th, 6th relapse to give to your patient Revdex, you won't get the best of the drug. If you want to get the best of the drug, you have to use it first relapse. Because well, I mean, maybe you should use it frontline. This is not part of my talk, this is Shaji's talk. But at least speaking of relapse, and speaking of the fact that in Europe it's approved for starting at first relapse. If you use it at first relapse, you do much better than if you use that combination later on in the disease. So it's true that I must admit that in France now, I would say 90% of the patients at first relapse receive Revlimid dexamethasone, trying to get the best of the drug, especially that it is a very expensive drug. I'm sure you know that. It's 70,000 euros in France, so I'm not good in math, so I'm not going to make the calculation, but Arthur, 70,000 euros a year, 70,000 euros per patient per year. So it's quite an expensive drug, but actually it's probably the best treatment, to my opinion, you could give to a patient at relapse, and especially at first relapse. I believe so. I mean, it's open to discussion. Further analysis, more analysis from the MMO9, MMO10, papers that I recommend you read from Wang, published in Blood a couple of years ago. I thought that paper was very interesting because I still have some questions about, I'm still questioning about should we use Revlimid? Revlimid is approved until progression. So you start the patient on treatment and you maintain the patient on treatment as long as it benefits from the drug. And I really don't know if this is necessary, if this is good. And there is an experience with talidomide, which is that Wang showed that if patients were put on thalidomide, let's say here, and maintained on thalidomide, if they stop thalidomide and great response, when they relapse, if you give them lenalidomide, so time free of treatment, they do very well with lenalidomide. Now, what Wang has been able to show was that if you maintain on thalidomide until progression, then if you give Revlimid, and if the patient was sensitive to thalidomide, he does good, but not as good as the first group. And there's a third group, those patients that relapse, that progressed on talidomide very early on, those patients, if you give them Revlimid, they don't do too good. So I think it's really a question for how long should we give Revlimid. Should we really give Revlimid until progression, or eventually if the patient gets a CR, complete response, after a couple of months, or maybe let's say 1 or 2 or 3 years, should we stop and wait the patient to relapse and then eventually start over? I don't know. There are not much data about that. The data we have though, it's a sub-analysis. Actually it's not this slide, it's this slide, but I'll go in the slide later on. So this slide is showing that the better response you get with Revlimid dexamethasone, the more you'll do good, and actually in terms of survival. So, but then what to do in a patient that would have a partial response to Revlimid dexamethasone if the tolerance of Revlimid dexamethasone is very good most of the time? You just maintain the patient of Revlimid dexamethasone, although you know he got a partial response, and eventually he'll be in that curve. So it's very hard to say I'm going to add a third agent to Revlimid dexamethasone just because the patient got a partial response, and while I would be happy to see a VGPR and better. So, but clearly, if your patient reaches a VGPR, you know that the chance to maintain on treatment and to maintain the time to progression will likely to be much better than if the patient gets another response not as good as VGPR. Now, what the slide was about, it was about trying to convince you, but honestly, I'm not entirely convinced, but trying to convince you that two things. First, you should maintain your patient on treatment as much as possible. And again, the approval in Europe is about maintaining your patient until progression. But another reason to maintain the patient on treatment is that apparently response rates keep improving even after 1 year, almost to 2 years of treatment. However, very few patients keep improving their response, but some of them might. And that eventually would, again, encourage you to maintain your patient as much as possible on lenalidomide. Although I do have patients that I have stopped with their treatment and they have not relapsed. They do very good. And I think today there is not enough data to tell us whether we should stop, when we should stop, or really maintaining the patient until progression. And again, I'm happy to hear from your experience. Now, a couple of words on something we have been working a lot in the IFM recently, which is the incidence and dealing with the guidelines published on the incidence of a thrombotic venous, especially venous thrombotic event in myeloma while on IMiDs. So I think, no.
Sorry. You showed the data about lenalidomide plus dex, and in your experience, you give always lendex, or you give solo len sometimes after half year?
No. Yeah, okay. I always start my patient with lendex, yeah. But after a couple of months, if I reach a plateau, yeah. And when I reach the base response, the plateau response phase, then I stop dexamethasone, because I don't like to maintain my patient on dexamethasone more than 6 months, 1 year. Because I think after they have all the side effects of dexamethasone, and I'm not convinced that they will gain more in terms of response. There's another reason, which is that there is a paper published. It's not from clinic, it's from the lab. There is a paper published in Blood, I believe, not this year, I think last year, 2010, saying that the immunomodulatory effect that you expect from lenalidomide, when you got the tumor effect, anti-tumor effect, what you have after that is probably an immunomodulatory effect. But there is a paper saying that if you combine with dexamethasone, because of dexamethasone, you lose the immunomodulatory effect. So the toxicity of dexamethasone for long-term treatment plus the idea that eventually you will not get the best of the immunomodulatory effect because you combine to dexamethasone is a good reason. Yes, sort of. It's a good reason for me to stop dexamethasone after a couple of months, but you have to keep in mind that you probably must stop dexamethasone only when you got the optimal tumor reduction, because dexamethasone is really part of the treatment. If you give lenalidomide only, it has no tumor reduction effect really. The tumor reduction effect really comes from the combination of Revlimid plus dexamethasone, I believe. So because in the lab, when I give Revlimid to cell lines, it just doesn't work. But when you combine Revlimid plus bortezomib, Revlimid plus dexamethasone, then you could see some anti-tumor effect. which I really believe it's what we're seeing in patients. So if you stop dexamethasone too early on, you might not get the best anti-tumor effect. But when you get the best anti-tumor effect and the plateau phase in terms of response and the patient does not improve response anymore, then I truly think that you could stop dexamethasone.
As a maintain, you should not give them dex because it's you have no plasma cells in patients after tandem transplantation, for example.
Well, I'm not speaking of maintenance. I mean, in the relapse setting, the approval is RevDex because the study has been conducted RevDex until progression. Okay. So the question is that if you really want to be in the approval, you maintain RevDex until progression, which I think is not good. Which I think you should maintain RevDex until you get the best response at the plateau phase, and when you get there, eventually you stop dexamethasone because you don't want your patient to suffer from long-term exposure to dexamethasone. And then the question is that do you lower the dose of lenalidomide then? Because you give lenalidomide at 25 milligrams per day. 3 weeks on, 1 week off. But then when you stop dexamethasone, do you lower the dose, let's say, to be as like a maintenance effect, which I don't, but some of my colleagues do. But I think the major problem is that we have no data. Okay. And Celgene will never give us data because, of course, if Celgene shows at some point that it's good to give 3 years and there is no reason to give until progression, for them it's so much a loss of money. So they won't do this kind of study. But it's too bad because honestly, it would be a very interesting study to demonstrate. Now back to the things that you have to be very careful with, which is the incidence of thromboembolic event that could go, in some studies, in combination with dexamethasone, it went up to 58%, which is really crazy to imagine that half of the patient got a phlebitis, a venous thrombotic event. Now there is this guidelines published by Antonio Palombo on behalf of the rest of the world, on behalf of the IMF, which I think makes no sense, and I really wanted to share that with you. Antonio Palombo, coming from nowhere, because I don't know which study proved that, said that if you have 2 of those risk factors, then you should be on low-wave molecular heparin. But if you have 1 of those risk factors, you should be on aspirin. Well, I do believe that this is based on no data, personally, and I do believe that if there is no apparent risk factors, of course, in France, most of the patients receive aspirin, but no one knows if it's smart because there is no data saying that aspirin has any effect as a thromboprophylaxis, venous thromboprophylactic drug. It's an arterial thromboprophylactic drug, but not a venous thromboprophylactic. We don't know about that. Maybe it has some, maybe it has none. So we don't know if you give Revlimid alone, should you maintain your patient on aspirin on nothing? But clearly, you don't need to have your patient on no molecular heparin. At least I don't think so. But if you combine to dexamethasone and anthracyclines, supposedly inducing very high rate of thrombotic event, in my experience, high-dose dexamethasone plus lenalidomide, you can give aspirin. It has nothing to do with high-dose dexamethasone. Because I have patients with low-dose dexamethasone that could have extensive thrombotic event and pulmonary embolism, and they only had low-dose dexamethasone. So the simple fact that you give high-dose dexamethasone, in my experience, is not enough to say that all the patients should have low-wave molecular heparin. So I think we really don't know what factor would encourage you to give low molecular heparin as per aspirin versus nothing. I really think it's an open field, and we really need to conduct studies to know more about this. However, I would like you to pay attention to this list here, because at the end of the day, even though we don't really have data in my understanding of what's published, clearly, if one of my patients have one of those factors here, I do give low molecular heparin because I don't want to expose my patient to any risk. So I believe that if you have prior history of thrombosis, you better be on low molecular heparin, because we know that a patient that had already a prior history of thrombotic event will do another thrombotic event very likely. And we know that Revlimid and dexamethasone, or imid and dexamethasone in general, triggers a risk to have another event. So I think that if you have those risk factors, you should be on low molecular heparin. But for the rest, I really have no idea. And actually, Xavier, I'm very interested in knowing how you do in the US. Now, one more thing I want to share with you is that if you have patients at relapse diagnosed with renal insufficiency in myeloma, it seems, as you can see, here you have patients that recovered, here you have patients that did not recover, and it impacts survival very, very strongly, published by Blade a couple of years ago, but it has been updated recently. There are data showing that it's very easy to use Revlimid and dexamethasone in patients with renal insufficiency. It's very easy. You just have to adapt. You go online, you type renal failure, lenalidomide, and you have a table. It takes 1 second, you can show to the patient, and you can say, you know, we are going to give you a lower dose because you have renal insufficiency. It's very easy to do. However, there are data that I don't show here because I'm limited in time, but there are data saying that eventually if a patient has renal insufficiency, you're better off treating the patient with bortezomib rather than lenalidomide. However, lenalidomide works very well. It's very easy to manage. You just have to lower the dose. But there are data saying that eventually with renal insufficiency, if you have the choice between bortezomib and Revlimid, you may better be off using bortezomib instead of Revlimid. But again, you may have patients with renal insufficiency that got Revlimid and did very well, and others with bortezomib that did not recover from renal insufficiency. But overall, the idea is maybe that with renal insufficiency, prefer bortezomib rather than Revlimid. There's also the thing is that if you do not decrease the dose of Revlimid in patients with renal insufficiency, you will have huge side effects, especially anemia. So you really need to decrease the dose. That means that you need to have a good calculation formula to calculate the renal insufficiency of your patient, which is very hard in elderly patients. Because if you take MDRD, it looks like all the patients do good. And if you take Cockcroft, it looks like they are end-stage renal insufficiency. So in young patients, it's very easy. In elderly patients, it's very difficult because there is no good formula. So I'll pass that just to say that the future Revlimid dexamethasone platform, as I told you now, it is our platform to treat patients first relapse for us, at least in France. So if you use Revlimid dexamethasone and if you want to improve on just this combination, we are going to start a trial with RD plus carfilzomib, which is the new proteasome inhibitor IV developed by Onyx. Epoxyketon, it's a different drug. It has nothing to do with bortezomib. Both of them are proteasome inhibitors, but different drugs, different chemical compounds. And MLN is another proteasome inhibitors, oral, developed by Millennium. So carfilzomib and MLN, we are going to try to combine those two proteasome inhibitors to Revlimid dexamethasone because in our experience, Revlimid dexamethasone combine very nicely with bortezomib. The combination of an imide and a proteasome inhibitor is so strong to control the disease that we really want to get rid of bortezomib because of the neuropathy effect, and we would like to test carfilzomib. Trust me, carfilzomib has zero neuropathy incidence, zero, not even 1%, zero. So it's really amazing. I have no experience with MLN so far. We'll start the trial soon, but I have a couple of patients treated with carfilzomib, especially elderly patients. It was very well tolerated. Now, it's going to be my task soon to develop a Revlimid dexamethasone vorinostat study. HDAC inhibitor, good thing, they're oral. Tough thing, difficult thing, they have a GI toxicity. So it's going to be, I don't know, we'll see. We experienced Revlimid dexamethasone plus panobinostat, and the study was a phase 2 study was stopped because of deep neutropenia. So I think Revdex does not combine very nicely with panobinostat, but it seems that Revdex combine very nicely with vorinostat. And David Siegel has extensive data in the US showing this combination. And we also going to combine an elotuzumab. I don't know if you heard about elotuzumab. I will just give you some data. I hope I'm not showing data that you will show, Shaji, because this is frontline. I encourage you to go listen to Andrew Jakubowiak, and I'm sure you'll be very happy to do, since he's Polish, for what I've known. He's Polish, right? So Andrew Jakubowiak has started one of the most amazing clinical trials so far in the last 2 years, which is carfilzomib Revdex. This is frontline, but it really tells us that we should test that in relapse as well, because in France we don't have carfilzomib frontline. We might have carfilzomib at relapse. So why I want to do that? Because as you could see, the toxicity profile, the tolerance profile is pretty amazing. As I told you, most of the side effects you could see here are side effects related to dexamethasone or to Revlimid, but none of them is related to carfilzomib. As you could see, peripheral neuropathy, almost nothing. And here, neutropenia is, as you know, Revlimid related. So in France, in Europe, and I'm sure you could be a center actually, there is this phase 3, and actually it's even in the US, I believe, phase 3 Aspire. It's a carfilzomib Revdex study versus Revdex in relapse refractory patient, 1 to 3 lines for registration. But the EMEA has asked Onyx to start an end-stage focus study, carfilzomib versus best supportive care for registration in Europe. This is very good because it would allow some of our patients that are almost palliative to receive carfilzomib. And at a great chance for those patients. Now, the best supportive care will be endoxan, cyclophosphamide, dexamethasone, which is not very active. So two-thirds of the patient will receive carfilzomib, but 1/3 will receive cyclophosphamide, dexamethasone. For that small group of patients, the chance to survive is very, very small. Just a couple of slides, and then I'll switch to pomalidomide that you're probably more interested in. A couple of slides to show you our experience with Revlimid, dexamethasone, and this new monoclonal antibody. You know that monoclonal antibody has been very disappointing in myeloma because the ADCC effect is really poor in myeloma. So if elotuzumab was quite interesting, first because it targets a protein called CS1 expressed on many cells, especially on tumor cells, on plasma cells. But another thing is that they believe that lenalidomide will rescue, will increase the ADCC ability, the T cells, NK cells, macrophage cells, especially NK macrophage cells, to perform the ADCC and then to improve the elotuzumab effect. I don't know if it's true. At least in the lab, it works. It's very well tolerated in our hands, at least in France. We have treated a couple of patients, more than almost 20 of them. And as you could see, the first 2 months, they receive a weekly infusion, and then it's a twice a month infusion. It's really, really, really easy to administer. And there is now a phase 3 study that I'll show at the end. What we were surprised by was this very high rate in patients that, of course, were priorly naive of Revlimid, but in patients that received carfilzomib, Revlimid, dexamethasone, naive of Revlimid, almost 95% of them got PR, and which at relapse is not very common to see. So we are very encouraged. And again, no toxicity profile. And I'll go directly to the current ongoing phase 3, which is Elocant 2, which is a Revdex elotuzumab. This monoclonal antibody is also called HULUC, H-U-L-U-C, Revdex plus elotuzumab versus Revdex. The clinical trial has started again for registration of this combination. There will be a frontline study, but I did put in comma because in Europe it cannot start so far because Revdex is not approved and because the company doesn't want to buy the Revlimid because if they start the trial in Europe, they have to buy the Revlimid and provide the Revlimid for free if it's not approved. But it costs so much money that they may not start in Europe this one. But clearly this one has started because my center has been opened like 2 weeks ago. Now, back to Shaji Kumar, our second guest here. He has published a paper that you must read, recently published in Leukemia. I know it was a tough fight to publish this paper. Maybe Shaji would tell us more about this publication. He has studied patients that were priorly exposed to bortezomib and animide. In some countries like Europe, France, etc., Revlimid. In other countries, talidomide. And he has shown that the median overall survival, the blue curve here, the median overall survival of patients that have been exposed to bortezomib and animide and cannot be exposed again is 9 months. Just to tell you that when you have a patient that is relapsing following bortezomib and eventually refractory to and relapsing following lenalidomide, and most of the time, because we give lenalidomide until progression, refractory to lenalidomide, the chance for the patient to survive is less than a year. So then we really need new agents and new drugs, and then we bring to pomalidomide. So I'll show you some data. I don't know if I'm late or not in my talk.
5 minutes.
Oh, you're tough. I said that I'll skip the dessert tonight, so I'll have 10 minutes.
It's okay, sir.
I'll take 5 minutes on my dessert tonight. So pomalidomide plus low-dose dexamethasone. We've been very lucky in France because Celgene gave us the drug for a phase 2 study, so about 100 patients. And 100 patients in France were able to get the drug, and trust me, most of them would have died within 3 weeks or maybe a month if they were not, if they had no access to the drug. So it was a real chance. Now the problem is that since 100 of them got the drug, millions of them, no, not millions, but thousands of them now don't understand why they can't have access to the drug as well. So it's really a problem. But pomalidomide plus dexamethasone proved to be, at least in our study, extremely well tolerated. The toxicity profile you should expect is exactly the same, I should say, than Revlimid. It has no neuropathy, few cramps, but neutropenia and thrombopenia. It's almost as if you give Revlimid. In our study, EPO, GCSF, any kind of transfusion was accepted, and in our study, all the patients receive a thromboprophylaxis, which is why we have seen very few patients that had to stop the treatment because of deep neutropenia. Very few patients stopped the treatment because of thrombotic event, and they were really able to maintain on treatment, which is very important because in our study, all the patients were refractory or resistant to bortezomib and Revlimid, as in Marta Lass's very recent paper that, and Mayo Clinic, she published in Blood like in two months, maybe 3 months ago. In patients that have received bortezomib and Revlimid, life expectancy is 9 months. So you must give the drug, any drug, whatever drug you're going to give, you must give the drug really at its optimal way. And the optimal way to give pomalidomide is to maintain the patient with the optimal dose. We believe the optimal dose is 4 milligrams. And if you can't maintain the patient on 4 milligrams, you can decrease to 3 and 2 milligrams. And we believe you should give dexamethasone to pomalidomide because there are data published from Paul Richardson in Boston showing that pomalidomide and dexamethasone gives better results than just pomalidomide, which is what you expect because, again, it's pretty much like Revlimid. Revlimid dexamethasone does better than Revlimid alone, especially in patients that have been relapse refractory. I just want to show you this. So this is something as a faculty, as an academic physician, I should never do, but just for the sake of the exercise, I did. I should not, but I did, which is to compare here the data from Shaji and here our data, just to show you that the time to progression with pomalidomide, even just to tell you one more thing about our study, we compared 3 weeks on, 1 week off Revlimid, the Revlimid way, if you prefer, to all continuous treatment, always on treatment, which is the thalidomide way, if you want. So either way, either arm gave 8 to almost a year of time to progression. We're not speaking of survival here. We're speaking of time to progression. And in the next slide here, you could see that after a year follow-up, and so those data are not this. After a year follow-up, I don't have yet the true data because it will be updated at ASH. So I can't show you this now because it'll be at ASH. I'll show you some things that I'll show at ASH. So you'll be the first in the world to see the next slide. But I can't show you everything. So after 1 year, you could see that almost 2/3 of the patients survive, which is unexpected. Unexpected. Look the curves in Shaji's data. They are so bad at 1 year. In our case, at 1 year, if you put 1 year here, look where we are. Look where Shaji's data are. So it's quite amazing. Now this is something that you're the first to see this data. And I'll be presenting an oral at ASH regarding those data. So what are those data? We have combined the 2 arms, starting with 84 patients. And then we thought that we would look at the effect of pomalidomide in various subgroups characterized with refractoriness. So we may not agree about whether those patients were refractory or not. Would you consider those patients truly refractory? We may not agree on that. But at least we considered in the IFN that those patients were refractory. Let's say, for example, if a patient was refractory to lenalidomide as per the IMW criteria, meaning progressing on treatment or within the 60 days after the end of treatment, then you could see that the response rate is 36%, meaning as good as all the patients in the study. That means that patients that had prior exposure to lenalidomide and were refractory do as good, which is good because that means that there is not necessarily a cross-resistance between pomalidomide and Revlimid, very encouraging. However, if lenalidomide was the very last line of therapy prior to start pomalidomide, and if your patient is refractory to lenalidomide as a very last line of therapy, then you don't do as good, which means that if you have a patient that is refractory to Revlimid and you want to switch that patient to pomalidomide, you probably better use another drug in between Revlimid and pomalidomide if you want to get the best of pomalidomide. Because if you go directly to pomalidomide following refractoriness to Revlimid, you lose some efficacy here. There's another group. So we went through all kinds of definition of refractoriness, refractory to bortezomib and lenalidomide, and last line, refractory to last line, 5 years from diagnosis to pomalidomide entry, 3 years, patients that only have 3 years from diagnosis to the entry into the study, which is really bad. They do all of them, they have about one third of them, 30%, 40% of the patient, they get response rates PR and better. So as per IMW criteria. Now, we were very interested in seeing this. Look, the deletion 17p, patients with deletion 17p, they do as good as the rest of the population, apparently. We only had a couple of patients, at least only 15 out of the 100 patients. But at least on those 15, apparently, the benefit of pomalidomide was really good. However, if you look at the line right underneath, the T414 apparently do not benefit much from pomalidomide. And actually, I'm interested in knowing what it's the same for you?
I mean, the PFS is really short.
Okay, yes, okay. So for deletion 17p, apparently they benefit. For T414, apparently they do not. Now, keep in mind that this is only 15 and 6 patients. It's a very small number of patients. And we in the IFM, so here I summarize the data. We in the IFM are going to conduct a study specifically, pomalidomide, specifically for patients with deletion 17p and T414. This is a summary of the major data you must know, I think, about pomalidomide. Paul Richardson study, pomalidomide 4 mg, 3 weeks on, 1 week off, in Revlimid, bortezomib, refractory patients. Marta Lassi, published, and myself, must soon published, I hope. And you could see that we pretty much have the same data. 1/3 of the patient can have a good response and maintain that response. Now, where are we going for pomalidomide? At least on our hand, we want to test pomalidomide in very elderly patients because we believe it's very well tolerated. We want to, and we are going to study in 17p deletion and T414, trying to confirm that 17p deleted patient might benefit from pomalidomide, and so on and so on. We are going to develop, I hope, because I meet with Onyx in New York in a couple of days. I hope pomalidomide, dexamethasone plus carfilzomib. I hope they'll accept to give me the drug. I don't know yet. And just to finish, I want to thank you very much. So I wanted to add here in Polish, but had no time. And just for you to know, I'm sure all of you guys went to France, but just in case, Lille, my city, is here. This is where I stay, so thank you very much. Appreciate it.